Recording in progress.
Hello and welcome. We'll get started in just a moment. We want to give people a chance to get logged in. So just give us a few moments. If you would, drop in the chat where you're joining us from. And if you're a new mom, expectant mom, someone who supports birthing people, the partner of, that'll give our speakers an opportunity to understand who they are chatting with today. So thank you. We'll start in just a moment. Great. We'll let people join in. I don't want to take too much of our time because I know we've got a lot that we want to cover. My name is Marie Boone Clark, and I am founder and executive director of Birthing the Magic Collaborative. We are so excited to partner with these amazing organizations to bring you this virtual maternal health fair. I'm even more excited to partner with my friends here today to talk about stress and how stress can and does affect your pregnancy. And so joining me today is Dr. Jamisha Connor. Dr. Connor is a physician, maternal health expert, and a fierce advocate for reproductive justice. She is also founder of Diasaora, which is a wonderful support system for birthing people. I'll let her explain a little bit deeper around the work that she's doing. And then joining me as well is Dr. Angela Neal Barnett, who is a licensed psychologist, community healer, champion of emotional well-being, and she too is doing some amazing work in the community. And then last but certainly not least, my newest co-conspirator in this work is Relicious Ebo, who is a thoughtful partner and researcher. And she has done some research around stress as it relates to your partner in pregnancy, and she's going to share some of her research with you. But I always stop and say, I want to honor what you guys are doing with your respective work. Words on paper never do it justice. So Dr. Connor, would you share a little bit with the team about Diasaora and the work that you're doing? And then we'll ask Dr. Angela and Relicious to do the same.
Hello, everyone. My name is Dr. Jamisha Connor. I am an OBGYN. I'm a mother of 3 and the founder and CEO of Diasaora. So DioSADA was founded to attempt to improve gynecological and obstetrical outcomes for Black women and other women of color. And we do this by really focusing in on obstetrical emergencies. Um, because our overall hypothesis is that if we can affect the events most proximal to the catastrophic outcome, then that's going to be the place where we will have the most impact. And so what that can look like practically can be education and reassurance if we feel like standard of care is being met, to working with the medical team to directly offer medical recommendations, requests, if we feel like the appropriate care is not being given, all the way up to legal interventions and coordinating transfers if we feel like malpractice is happening.
Thank you. And I keep calling it a concierge service. And my testimony is I've got 6-year-old grandchildren, and had 6 years ago, Dr. Connor had this service as a grandmother, as a mother of a Black daughter. I would have moved heaven and earth for her to have this wraparound service. I just dropped the link for DioSADA in the chat so that those of you who can find Dr. Connor. And then Dr. Neil Burnett. I stalked Dr. Neil Burnett when I don't remember if someone gave me the book or I found her book, but she has a book that you all must read, especially, oh my gosh, just think, if I hadn't read your book 2 years ago, I needed it now. We all need it now. Dr. Neil Burnett, share with us your work, but also I will drop the link in for your book.
My name is Dr. Angela Neal Barnett. By day, I am a professor at Kent State University. By day, and by night, though, I direct something called the Spirit of Motherhood Initiative, and where we are what are called intervention researchers. So we provide mental health interventions in the community to Black perinatal women. And we do this by using doulas, community health workers, counselors, and even we have community liaisons. One of the things, and we're going to talk about this a little later today, is that we know that there are all sorts of reasons why Black perinatal women, why Black pregnant women, Black women who are postpartum do not seek out mental health services. Uh, we make it easy for people to do that because we are embedded in community organizations. And we have, through our interventions research, developed effective, safe, and low cost and brief treatments for PTSD, which is caused by trauma, for anxiety, and we were talking earlier in the practice session, and for grief. And so that people can come to trusted organizations within the community, urban leagues, settlement houses, and we're embedded there. We have people there uh, who will uh, who will deliver the intervention. And we know that one of the leading causes of maternal morbidity and infant mortality relates to the mental health of the mother. And if we can make those, if we can partner that mental health intervention with the physical health intervention, then we increase the likelihood of healthy babies and healthy mothers.
Thank you, Dr. Neil Barnett. And I dropped the link for her book. The title is Soothe Your Nerves. And we all know we need this right now.
Yes.
And Relicious, last but not least. But and we'll talk about Relicious's research when we get to that section. Why don't we do that? I want us to dive in. Dr. Jamisha, I want us to first, if we could, just to frame the conversation, walk us through the role that stress plays in maternal health and birth outcomes, if you will. Like I think we've all probably seen the statistics from March of Dimes and that sort of thing about the increase in premature births. But would you, in your beautiful way, share with us how it affects us physiologically?
Of course. So as many of you are aware, Black women face disproportionately poor outcomes in pregnancy. We are 3 to 4 times more likely to die from pregnancy-related causes. We're also twice as likely to experience severe maternal complications. And so that could be anything from a hemorrhage to a cesarean hysterectomy to prolonged stay in the ICU. But it doesn't just affect us as pregnant women, it also affects our babies, giving higher rates of preterm birth and low birth weight. And this persists despite income and education. And so this is not primarily resource driven. Something else is contributing to these outcomes. We know now, we've had sufficient data to show that chronic stress is a major contributor to poor pregnancy outcomes. As Black women, we face the stresses that are innate to motherhood that all women face, as well as unique stresses from racism and discrimination and just where we kind of sit in the ecosystem. And so what this ends up doing is promoting a you all have probably heard of the fight or flight response. Well, your body, when you have a high level of stress, is always ready to, it's always amped up, it's always ready to fight. And that is done by stimulating hormones. So cortisol is a very common one, but there are several other hormones in the pathway that rise when you're chronically stressed. And so what does this lead to? This leads to chronic inflammation. This leads to hypertension. And this leads to weakening of the immune system. And over time, all that extra stress has a cumulative impact on the body. And if you have a stress exacerbation, particularly during pregnancy, that can trigger, for example, preterm labor by triggering directly uterine contractions or premature rupture of membranes. The most recent study that I found showed that Black women, they studied a group of almost 2,000 women. 62% of them were Black, so this had a nice population size that was representative. And it showed about 15% of the women from the preterm birth rate group also had really high levels of stress. And the way that they measure the stress is not just by you and I reporting that we feel stress. They're measuring this by looking at hormones, looking at other physiological markers. This also affects how the baby grows because stress is important for the hormones that chronic stress generates also have an effect directly on blood vessels. And so that leads to restriction of blood flow from the placenta, and the placenta is how the baby gets all of the nutrition. And that can directly lead to impaired fetal growth. Black women have the highest rate of low birth weight infants in this country, as well, I think, as the highest rate of preterm labor.
Thank you. So we've established how stress affects us physiologically, right? And this might be a question for Mel. I want to ask the question. I'll let Dr. Neal Burnett take us down this path first, because I always want to dive in. You know how I am. Thank you for Dr. Connor. Where I was starting to go was understanding that stress is not always like a car accident or something major, that there are smaller microaggressions and the things that we live with. But I know that's where Dr. Angela is going to take us. So I will stop talking.
And Thank you, Dr. Connor, because that really sets the stage for what I'm going to talk about. And basically, it's how these hormones, particularly a hormone called cortisol, really plays a role in plays a role in the development of, uh, of mental health disorders. And so what I want to be really clear is that the biggest stressor that we face as Black women uh, is racism. And one of the things I think we have to be absolutely clear about, it's not the fact that we are Black that is giving us these high rates that Dr. Connor has talked about. It's the fact that we are Black in America and that the chronic racism that we face, regardless of our socioeconomic status, uh, places us at greater risk for infant mortality and for maternal morbidity. And in fact, one of the facts that most of us know is that a Black woman with a PhD or an MD or a JD is more likely to lose her baby than a white woman with a high school diploma. So stress is not new to us. Since the earliest days of enslavement, Black women have known uh, have known stress, and they've known the stress that comes along with infant loss and trauma. And the other side of the photo is a woman from the 2000s, and she is chained to a bed. And you're thinking, well, why is she chained to the bed? And the fact is, I'm from Ohio, and in Ohio, if you were in part of the Department of Corrections, the prison system, and you were pregnant, when you went into labor, they chained you to the bed. Now, I don't know how many people have been pregnant and given birth, but the big question we always ask was, where are they going to go?
Right.
Yeah, where are you going to go when you're in the midst of labor? But imagine the stress that that has during the birthing process, being chained to a bed to give birth. So stress is nothing new to us. Okay. And when we combine the stress of racism with other stressors, then we are facing high levels of chronic stress. So most of you have seen this, black don't crack, or you've heard somebody in your family say those words. And it's absolutely true. And in fact, there's research, dermatological research, that tells us that black really doesn't crack, that black skin, because of the melanin, ages differently than white skin. So that's why you can be 70 and look 40, because black really doesn't crack. But stuff happens on the inside. And that's the stuff that Dr. Connor was talking about. And one of those stuff and that's the stuff that's the stuff Dr. Connor was talking about. And one of those stuffs is the cortisol. And cortisol is one of the stress hormones. In psychology, we say it is the stress hormone. And cortisol works a lot like what happened to me when my daughter turned 16. I threw her the keys to the SUV and I went down to the dealership and I bought myself a grown woman's car. Now, for those of you who do not know what a grown woman's car is, it only holds grown-ass people. So I wheeled that baby off the lot, popped the top, and I drove down 77 south, going 77 miles an hour for 77 miles. At the 78th mile, the car started making noises. At the 79th mile, steam rose from the engine. And at the 80th mile, the car just stopped. It would go no further. I had burned out the engine. So when I was driving as fast as I could, that's what happens with cortisol. It's these high levels. But I had run at those high levels for so long and for so hot and so high that eventually it quit. And those are low levels of cortisol. And high levels of cortisol are associated with depression and stress. And low levels of cortisol, or what we call blunted cortisol, is associated with anxiety and trauma. So, what happens to us? Okay, on the outside, we look good. But on the inside, those hormones, that cortisol, is taking such a toll on us that it increases the chance that we will have health and mental health problems at a younger age. And that is called weathering. Okay, that is called weathering. So we're not weathering on the outside, but we are weathering on the inside. And Dr. Connor spoke to how that impacts uh, impacts our pregnancies and the baby's growth. And I'm going to speak to how that impacts our mental health. Okay, so the unrelenting stress of racism and all of its consequences often results to something called perinatal mood and anxiety disorders, or they call them PMADs. So if you're on a website and you're looking at it around, it says mental health PMADs. This is what they're talking about. And one of the things that we have known that since the pandemic, anxiety, isolation, and loneliness have reached epidemic heights among Black Americans, particularly Black women. So, this weathering, which affects our inside, affects those cortisol levels, then leads to PMAD. So we have anxiety, social anxiety, which is basically what must other people think. Panic attacks, which are probably the most common form of anxiety we see during pregnancy and postpartum. And then generalized anxiety, which is what ifs, what is somebody who's full of what ifs. Then and again, this is associated with low levels of cortisol. PTSD, which is like when we've had some life threatening event or some chronic event that we have no control over, this chaos in our lives. And a lot of the women that I work with have had chaotic childhoods. And so we see that they have that they have PTSD. And then depression. Remember, depression is associated with those high levels of cortisol. And we think of depression as being sadness. You're sad more days, you're sad most days. But when we think about depression with Black women, particularly with Black pregnant women, we have to be aware to look for isolation, to look for loneliness, and to look for irritability. So whenever I see a so-called angry Black woman, I'm looking at for two things. Am I looking at depression, or am I looking at social anxiety? Because when you are socially anxious, when you are, you care about what must other people think, sometimes you put up an irritable facade to keep people from judging you. Okay. So when we're out and we're working with women, many of them are unaware that what they are experiencing is anxiety or depression or post traumatic stress disorder. And in fact, we hear this time and time again. What? You mean this has a name? We just thought it was the way it was supposed to be. So think about this for a minute. Imagine experiencing PTSD or severe anxiety and thinking that it is the way it's supposed to be. That means you've experienced it for longer periods of time. And many times the symptoms are stronger. So I want to be really clear that, particularly for PTSD, becoming pregnant is not what creates PTSD. Many people have PTSD before that and then go into the pregnancy with those PTSD symptoms untreated. This is not true for pregnancy anxiety or pregnancy depression um, or postpartum depression. The onset of anxiety and depression is in those is in that perinatal period. So there are all sorts of barriers. So if we know all this, and we know that racism is a stressor, and we know all the other stressors that Black women face. When we ask Black women, what are your major stressors? They say, my man, my kids, my money. Okay, so when we put all those together and then we add in these social determinants of health, that creates barriers to seeking help. Okay, first of all, one of the barriers is, and we see these stories over and over again, no one listens to pregnant Black women. Okay, and it doesn't matter, and it doesn't matter who we are. Serena Williams, multimillionaire, married to a billionaire. Beyonce, multimillionaire, married to a billionaire. Both both experienced life-threatening pregnancy, life-threatening events during birth. And yet, they couldn't get anyone to listen to them until it was almost too late. So, because people don't listen to pregnant Black women, we are missing sometimes the mental health uh, disorders that they are experiencing because the standard instruments that we use result in Black women underreporting their symptoms. But when we hold structured conversations with Black women, they report their symptoms as they are, which says if we're going to identify anxiety, PTSD, and depression in Black women, we have to think outside the box and not just use these standard checklists and instruments. So, other barriers that we run into, okay, is once we know, once we've identified that, look, yes, I'm experiencing anxiety. That is the name of it. Yes, I'm experiencing um, depression. That is the name of it. Is that there's this cultural mistrust. So if we say, okay, we're going to refer you to a therapist, they won't go. And one of the reasons that they won't go is because of this fear that that their kids will be taken away from them, or that when the baby is born, it will be taken away because I said that I was sad, or that because I have because I have panic attacks. Okay, That's not why children get taken away. And I'm going to be real clear. Children don't get taken away because you are experiencing anxiety or depression or PTSD. So, what we know from the data is that if we can overcome cultural mistrust, okay, if if we can match the therapist's race and gender with the race and gender of the mother, then we see more improvement with the mother that they'll go. The Black mothers will go to see Black therapists, but there aren't enough Black therapists around going around. So then we have to come up with low cost ways to do so. And that's where the circles or the sister circle uh, motif comes in. And I'll show you in a little bit. And how am I doing on time? Do you want me to wrap it up right here, Marie, or can I go on? I didn't hear what you
I'm
said.
sorry.
I'm sorry.
I was muted. Excuse me. I think there's some good points here, Doctor. And we're doing okay. We're doing okay
Okay.
for time.
Okay. So I'll keep going. And then there's so and then there's stigma. I mean, what does it mean if I have to go see somebody? Does it mean I'm crazy? And how mental health is viewed in many Black communities. So I will say this: there is no sin and there is no shame in needing mental health counseling. Where the shame comes in is when you know you need help and you don't ask, and it gets worse. And then you get into this cycle of thinking that you've done something wrong and the cycle that you're so ashamed. It is never too late to ask for help. Okay. So this is my favorite picture because I just think the baby's balancing in the warrior pose is just really an amazing thing. Um, and maybe because I can barely balance in warrior pose might be. But we looking at all of this and looking at what we knew, what our research was showing about Black mothers, we developed sisters offering support, sister circles. And we have a couple of them. We have one that's all about anxiety, and that one is 7 sessions. And as we were out trying to figure out what is it that our perinatal moms need, we ran focus groups. And one of the things that we heard over and over and over again was that many of these mothers, many of these women viewed parenting as a burden. And the reason they did was because they had no models of how to parent. And so we developed also a stress parenting sister circle. Um, there are various things we do. We have videos, we have music, and we have a music intervention that's part of it. And women come. They come because they're learning, it's changing their lives, but they're also coming because they're isolated, and that it brings them together and they really do form a a sisterhood. And the anxiety sister circle is based off of my book that Marie was talking about, Soothe Your Nerves, The Black Woman's Guide to Understanding and Overcoming Anxiety, Panic, and Fear. But when we were out doing the research, and we were out doing the interventions, and we're in the sister circles, what we heard was a lot of trauma, and trauma that was untreated. Uh, and the symptoms were those very much like what you see, what the symptoms were PTSD symptoms, where people were having flashbacks. And they were having flashbacks in the circles, or people were hyper vigilant, or certain things would set people off because it triggered them. So, so we added to the spirit of motherhood by uh, doing one-on-one interventions. And these one-on-one interventions, everything we do is brief because when you are pregnant, when you are postpartum, you don't have a lot of time. Um, and so everything we do is brief. And we use something called written exposure therapy, or WET. And so WET is basically having the mothers spend 30 minutes writing about the trauma. And it's a manualized treatment. And what we have found is that WET with Black perinatal mothers is quite effective. We've been able to reduce symptoms, PTSD symptoms, 50 to 100 months. So we have this, so it's this effective treatment. And because we know the barriers, again, everybody who does our mental health interventions are Black. So doulas lead our sister circles, and we train them to deliver this mental health intervention. Uh, and then we have Black therapists who deliver WET. Oh, it's okay. So I just want to give you my contact information, but I also want to say very, very, very clearly that mental health, as we look at pregnant women, as we look at Black women postpartum, we cannot ignore their mental health. And a lot of the mental health treatment that we can make available is culturally competent. It is brief, and it really does make a difference. So I'm going to stop sharing here.
Thank you so much for that, Dr. Angela. Before we move forward, I know, not I know, I would like to know, Dr. Jamisha, if there's anything that you want to add, if you want to, can we talk a little bit from your perspective how experiences in the clinical setting can often be one of those stressors?
Yeah, so, you know, women come to the birthing experience with a varied background. Some of these women have had prior birth trauma, and prior birth trauma, or either you've experienced it directly or even through someone that you love, that creates um, a a discomfort with the medical community, particularly if it's not managed well. Um, uh, what I'm thinking of now is stillbirth. You know, when a stillbirth is diagnosed, it's one of the most traumatic experiences for the mom. Like I still remember, like, you know, when you diagnose it, the screams that you hear from mothers, it's like something that stays with you. And obviously, this is a very difficult situation for everyone to manage. The family, the care team, and unfortunately, there are a lot of care teams who do not have the appropriate training, and aren't able to help women start to process what has happened. And so often, many patients that I have seen that have experienced a stillbirth have both the trauma of the stillbirth, but also the trauma from how it was managed on labor and delivery. So, for example, uh, sometimes people aren't familiar with the particular case, or what the clinical situation is, and so they might walk in the room and make like a very insensitive comment. I've heard of some providers asking to see the baby, or commenting on the baby's color, not kind of knowing the context. And very often, people don't recognize that once you're past a certain gestational age, then most likely you'll need an induction. And so if you've ever had an induction, those can take a very long time. And so you are kind of stuck on labor and delivery potentially for days in this very uncomfortable environment, without the appropriate support. And that is one of the major sources of trauma that I've seen that's directly associated with like the birthing process. But Black communities in general have medical distrust of the medical system as a whole, from a long legacy of experimentation, starting in slavery and continuing to the present day. And then the current day health inequities that we see, what that should tell you is that most people of color are not being treated appropriately by the medical system. We know that in the obstetrical space, 80% of the mortality cases were preventable. And so that should, suggest to people that these women, these families are having such a difficult time communicating with the care team and receiving the care that they need, that it's resulting in such a catastrophic outcome, which should be fairly rare, particularly with the types of causes of death that that we see for Black women in this country. Those are things that often could be prevented. So for example, um, you know, there are certain obstetrical emergencies that we don't really know how to solve, and we don't have any tools or medications to treat. If that happens, then there's very little that we can do. So an example is an amniotic fluid embolism. But there are a lot of obstetrical emergencies that we do know how to treat. But when it comes to Black women, they unfortunately don't receive the appropriate care, or the care is delayed, or the care is given in a way that's not consistent with what standard of care would be. And the outcome of that are these poor outcomes. And that can range from, we focus a lot on the mortality statistics, but the morbidity statistics are also very high, meaning these are women who, again, are having a traumatic experience. They're spending multiple days in the hospital. They potentially have ICU admissions. They maybe have required a hysterectomy. So pregnancy can be quite a complicated experience for Black women, particularly if they don't have the appropriate support systems to be able to guide them and defend them if and when necessary, against a system that is unfortunately just very hostile to people of color.
And that's a perfect segue, Dr. Jamisha, and thank you for helping us frame that. One of the questions in the chat was around support, the support network. What are the top 5 things that you would suggest or direct doulas to do immediately upon notification of a stillbirth, prior to connecting the birthing individual and tribes to culturally congruent and relevant counseling or therapy?
So this is a doula asking what should she do for families, or can you clarify that a little bit?
What are the top 5 things that you would suggest or direct doulas to do immediately upon notification of a stillbirth? And then it goes on to say, prior to connecting the birthing individual and tribes to culturally congruent and relevant counseling.
Okay, I see. So this is, so what I'm assuming that question is saying, correct me if I'm wrong, is when the stillbirth is first diagnosed, what are the things that a doula can do in the immediate aftermath to help support their patient? And so, the first thing is just being there. this is often going to be a long process for the family. And many people don't realize that, you think you go into labor and you expect to have a live baby at the end. Um, it's hard to imagine having to do the same labor process, but then not having a baby.
Mm.
And so even the most well-supported person is going to have a very hard time with that. And so if you have patients who have minimal supports, or if you just know them well, I think the first thing I would do is ask them, do you want me to come to the hospital? How can I support you? Who can I call? The other thing that I have seen doulas be very helpful in is coordinating with the patient's religious community, because that's often a time where families need a lot of support, and that is, the hospital systems have their own chaplain, but that person doesn't have any connection to the patient, and so it doesn't provide the same support. In terms of what you can do to try to ensure that that the patient, and this is not, of course, your responsibility, but there are certain things that need to be done um, to when someone has a stillbirth, in order to, one, make sure we're collecting all the information we need to help them understand why this might have happened, and two, to make sure they're having, as traumatic free of an experience as possible. So the first thing is everyone on the unit should be notified that this patient's room is not to be entered. So a lot of times when a patient has a stillbirth, we try to minimize the back and forth. And so there's one nurse, one set of doctors, so that, even for the little time they know each other, there is a relationship. And so that's one way a doula can help. If you're not seeing those sort of like protocols being followed, that would be inappropriate. Making sure that the patient receives, is counseled about the different types of ways that they can deliver. There are different sorts of medications, and the specifics I wouldn't worry about, because that's, I think, beyond your scope of practice, but just making sure they're receiving that counseling is important. If your patient is interested in getting more information, which most moms are, then, talking about and making sure that the facility is offering things like genetic testing or an autopsy, so that there could be an opportunity to learn if there was a preventable cause for the stillbirth. And that often will get forgotten, which is a real tragedy, because that mother's looking, people can spend years looking for why. What did I do wrong? What did I do? And often it's probably nothing, right? These things unfortunately happen for a variety of different reasons that we never really understand. But moms and families should have the opportunity to get that information if it would be healing for them. Some families don't want that, and that's totally fine. But for the patients that do, they need to be given the option. And then the last thing is making sure that if the patient wants time with the baby after delivery, that is also an option. We don't have to rush the baby off right away. There are little bassinets that will actually keep the baby cool, in case patients want to keep the baby with them for a few days. And so if they're not being offered that, that's another way that you can, just remind the care team, does your hospital offer these sorts of resources? And then the last thing is just making sure that the memory box is prepared. And so this would include things like the footprints. Um, Oftentimes, everyone on the unit will sign a card. So just little ways that they can honor their baby, um, and a way that the hospital can communicate that this is you are important to us. Your baby is important to us. And if that's not happening, that's again another thing that the doula can help facilitate, because a lot of times when there is a stillbirth, some teams are just really uncomfortable in that situation. And when people are uncomfortable, then they tend to just avoid those patients.
Right.
And that's obviously not the right thing to do. But if you see that happening, as an advocate for the patient, you can step in and try to, make sure these things are happening and the process is moving forward and people are explaining to the patient what's going on, how long is the induction taking, what methods they're using. Um, because some teams do a really good job of it and some teams unfortunately don't.
I think you make a good point, Dr. Jamisha, about advocating for mom and being able to intercede when things aren't, when you can see that the support is not ideal. And which leads me to thinking about Relicious and her research with the partner, the importance that the relationship with the partner. Um, Relicious, in your experience, what are some things that dad or the partner can do in either, and whether we're talking about, I don't want us to I mean, obviously having a loss is a major component and is fresh of mind, I think, with Dr. Jamisha and I, because it came up with one of our other workshops. But how can dad or how can the partner be supportive? And then let's talk about what your research showed when the partner is not supportive.
Yes, so in terms of how a partner could be supportive with his spouse or other partner experiencing a stillbirth would definitely be providing continuous emotional support and acknowledging and validating their grief. And that could look like giving the partner enough time to grieve and not trying to rush the process of thinking about, okay, when could we possibly have another child, letting them be still in the moment of the fact that they are experiencing a traumatic event, and then also giving them support to feel their feelings, and then trying to do things for their partner that shows that you are there for them, whether that be once they leave the hospital, try to commemorate the loss in some way so that that moment is also not taken away. And then practical support would be, of course, doing some household tasks, possibly attending counseling in some way so that they can grieve through the process together. And then also trying to create more new memories and to not shy away from the grief, but also understanding that there's still more to life than the grief that you're experiencing. And also, of course, respecting the grieving process.
That's I think that's when we need to pin on here is respect the grieving process, because I would suspect, Dr. Dale Barnett, that we all grieve differently, right? That so, even between my partner and myself, he may be someone who just wants to avoid it or wants to go on, and I still need time, or vice versa. That maybe the woman is saying, I don't want to live in this, I don't want to sit in this, but he needs time to grieve. So how would you, what are some of your pearls that you would share around understanding the difference in?
I think it's really important to remember that the loss of a child is the most stressful thing that can happen to someone. And that the research is really clear on that. People do grieve in different ways. Um, and one of the things that should be offered uh, after a stillbirth is just information about uh, grieving groups or grief groups, even if the parent um, doesn't want it then. Uh, just so they have that information available, because it may be a year or 2 years before someone says, I really, I think I really need help with this. Okay.
Mhm.
Death of a child often drives partners apart. Okay. So
Mm.
even if, unfortunately, that's what we that's what we know. And so it's important for each person to acknowledge, to acknowledge, I know you're not doing it in the way that I'm doing it, but it's important for us to acknowledge that and just check in with each other about how we are doing. And as Dr. Connor says, there are really different reasons for a stillbirth. And so what we have to be really careful about and be and um, partners have to check in with each other is that people are not blaming themselves, or that one partner is not blaming the other. Okay.
Mhm.
And it's, and if that's how one is feeling, I mean, being honest about, I know I shouldn't feel this way. I know that it is not your fault, but this is how I'm feeling, and how do we get past this? You know, as opposed to keeping silent. And that's where um, therapy counseling can be really helpful, because the partnership, the couple can come in and, in the presence of a therapist, talk about this. Um, I'm a big believer in grief recovery. There are grief recovery groups that really help people go through this process in a way that is productive for everyone. So, yeah.
So true. Thank you. That's very thoughtful. Um, I know it's unrelated, but I think so rarely is this discussed. So it's maybe a little bit off topic, but I always think we should, when we have exposure to experts like you guys. Dr. Jamisha, you made a comment where you said, when you were answering the question around the role the doula can play, right? Mom has experienced a loss, and something you said sort of pinged for me, is encouraging mom to ask that the baby be autopsied in an effort to identify if there's a reason why. Can you elaborate a little bit more on that for us? Because so often we hear of mamas who've had 2, 3, 4, 5 losses. And that's not an indictment of her, but she's told just keep trying. Help us ground us in this science of why we should be looking a little closer at what caused the loss of this baby in an effort to mitigate her having another one.
Right. So anytime someone has recurrent pregnancy losses, it needs to have a workup. You're going to do something different if those losses are occurring very late in pregnancy versus typically it will be a lot of first trimester miscarriages. And after the second one, the standard of care is to offer the workup. And that workup includes looking for uh, any sort of underlying chronic disease. There are a lot of antibodies that we know that are linked to certain syndromes that lead to recurrent pregnancy loss. There might be anatomical reasons. And so it's a pretty comprehensive review. Your general OBGYN should be able to do it, but if not, then a reproductive endocrinologist will definitely be able to offer that. When you're talking about stillbirth in the third trimester, that's a little different. Um, so most of those babies, by that point, you will typically have an understanding of the baby's genetics, if there's a genetic abnormality, because of first trimester and second trimester testing is so prevalent now. But what the autopsy can tell you is about other things. So, are there particular syndromes that wouldn't show up in the genetic testing, depending on what sort of testing panel you received? Were there issues with the placenta? So you might have had undiagnosed severe preeclampsia that resulted in a miscarriage, and the way that you eventually get that diagnosis is by examination of the placenta. Um, Often, a lot of intrauterine infections. So we have infections called the torch infections. It's why they tell you not to like touch cat litter and not to eat raw deli meat. It's because there are certain infections that for mom, she may not be affected, but can be catastrophic for baby. And when I have seen the autopsies actually determine something is that is useful for mom, it's either undiagnosed diseases in the preeclampsia on the preeclampsia spectrum. So preeclampsia, HELP, severe preeclampsia, or an undiagnosed infection. The other thing that's quite common is a cord accident. And so that's exactly what you might think it is. The baby has a lot of umbilical cord, and that umbilical cord is really squishy. And that squishiness, what it does is that protects the vessels that are inside. But sometimes, if you have, again, certain chronic diseases, your placenta is not as like robust. And so that can result in things like cord accidents, or again, small babies, and in a very small number of cases, stillbirth. The one disease I would say that scares me the most, whenever I see a patient, and often these patients don't recognize this, um, a patient with type 1 diabetes that is poorly controlled is at very high risk. And that's not that uncommon in this area. In the area I live now. I live in North Carolina, and in some of the rural communities, I
Mhm.
see a lot of that. Just very, very poorly controlled diabetes can have really catastrophic outcomes for both mom and baby.
Thank you. I appreciate you summarizing for us why it's so important, because if families go home, right, without answers, without support, without an understanding of, what to expect next time, it it leaves room for repeat experiences or untreated stressors. And speaking of stressors, I'm being attention deficit, but I want to go back. When we were talking about stressors, Dr. Angela, so often I think for the average layperson, when we talk about stressors, we think about losing our job, losing a loved one, losing that baby, those big things. But could you share with us what are some of the quieter, more chronic stressors that show up in everyday life for Black women that can also lead to that cortisol experience that you described?
What we find is it's some form of racism, whether that be a microaggression which was oftentimes interpersonal, whether it's systemic, or whether it's that the mother has internalized some message uh, that people have said about her because she is Black and she is pregnant. And we find on average with our moms that that they can identify at least one major race, I'm sorry, two major racist events in a month that uh, have have happened to them. Uh, Also, one of the things that we have to take into account is that some moms are the only Black person uh, in their in their workplace, and what that means. And when you're balancing, so those stressors of racism, those microaggressions, those small daily little things that kind of nag at you are stressors that women experience. The other thing we see are uh, racism is a social determinant of health, and and it impacts other social determinants of health. So things like transportation, uh, things like housing, and we find that a lot of our moms are basically couch surfers. So I mean, imagine being pregnant and not really having a home. So they may be staying with the partner's family. And if they have a fight or if they and the partner fall out, then oftentimes they're asked to leave and they have to find another place to go. Um, and Many of them, if they have their own transportation, um, it's old or it needs repair, or the car needs work, and they don't have the funding to get the car fixed. Uh, or if they are, if they're using mass transit, they have more transfers uh, than than other than than other mothers do. And I think Dr. Connor spoke to this, just what happens to them in in going for their visits, for their wellness checks, their prenatal visits. This is where I think doulas are so important because they're there with them. And so when uh, they are treated badly, I'll tell you a story. One of the things that we had happen um, was a lot of our moms would show up would show up for the visits with bonnets on and t-shirts that just barely stretched across their bellies and sweatpants. And so of course, they would be that oftentimes the healthcare professional would treat them in a condescending, somewhat racist way. Again, listening to Black women, what these women believed was that if they dressed nice, that people wouldn't think they needed help. Or they wouldn't think that they would think they were abusing the Medicaid insurance that they had. The other piece was the bonnets were on their heads was because when you were pregnant, the strong recommendation is that you not chemically alter your hair. Okay. Okay. And old school hairdressers had said this for years, and then somebody did the research and said, yes, this is true. But all the hairdressers were telling you this from the very, very
20
beginning.
years ago, well, 43 years ago.
Yeah, yes, that's what.
Yeah.
So yes, so um, so and black hair care is expensive. Okay, and you just can't go from if you're altering your hair, you just can't go from altering your hair to a natural style and braids, etc. Sew-ins are also expensive. So they
We
were
now know that the hair that's used for braids is
yes,
that some of the hair is not as
yes.
yeah. So
And
that's
so all the things that the hormones do to your hair, plus what you can't do to your hair. And so wearing the bonnet was just covering the hair because they didn't want to go out with their hair looking bad. But because it was a bonnet, okay, people that they would overhear people in the doctor's office
Mm,
talking about them, and not the other patients, but
the team.
yeah,
Right.
the team, the team talking about them. So these are all stressors. One of the things that we teach is how to wrap your hair. How to so we give people we give them our mom scarves and we teach them how to wrap. And so instead of going out with the bonnet, they go out with the wrap. And they feel better about themselves because wraps are beautiful and they're very easy to do, so they feel better about themselves, their body image, uh, and so it's a mental, so it's a slight mental health intervention, but also then they are able to stand up for themselves in the doctor's office. But these things, we just transportation, racism, housing. Um,
We're all big.
Stressors that many of the women we see, and we work in urban areas, uh, and many of our women, their insurance is Medicaid, but these are stressors that they're facing on a daily uh, level, and I think the most I think
It's not the big things. It's not, it doesn't have to be, and I'm going to say this, it doesn't have to be, I have a partner who's not, who's not with me or who's not engaged. And I want to talk about the partners a little more because this came up with one of our dad workshops earlier this week. But before I leave, I've been hanging out with Dr. Jamisha too long because my first thought when you said that the staff was being unkind
mm,
was we need a training for them. We need a training for them that says
yes, we
what
do.
mama wears and how she looks should not affect. I know, I know. So I've heard you, Dr. Jamisha. Did your ear do that too? Tell the truth. Didn't your ear do that?
Not anymore because we've had a lot of training. It's not for lack of training,
Oh, so it's not,
unfortunately.
yeah. And I know I've
So
heard it. I've been in I mean, because with being in pharmaceutical sales and for so many years and being in the office, they tend to think of you as one of their team. And you hear them, or you hear them and I will say this, one of my most disappointing moments was there was a physician that I had always admired, and I have so many that I do for various reasons, from my 40 years in this work. Well, in my work with pharma, and I was telling a doctor that we were about birthing the magic and that we were going to do this, and this is someone of color, and her response was, well, good, you can do a workshop on encouraging mamas to shower before they come for their appointment. Um, and sometimes I still have to work on being diplomatic because my first answer was, well, you are in one of the hottest states in the country. Why wouldn't you have like the little, wipes in the bathroom? Because how many buses did she have to get to you? And even if she didn't have to do a bus, she had to ride in a car and it was hot. And then it was like, okay, never mind. But I say that to say that our bias can often be completely unchecked, unrecognized, so stepping back, one of the things that Dr. Angela was describing to me is that mom has to navigate a lot, right? She has to navigate the changes in her body. She has to navigate, the lack of energy. She has to navigate. Relicious, in your research, talk a little bit about the importance of that partner. And we're saying partner because we want to make sure that we're saying that even if that's not your husband, if that's not your dearest, as I call mine, your partner, the person who has helped you who has fathered this child, what's the role and how can they support mama?
Yeah, so in my findings, I did find that when partners are actively involved, it can significantly lower stress levels throughout the pregnancy. So before pregnancy, partners can help manage expectations and anxieties about the journey ahead. And so also during pregnancy, having consistent emotional assistance or reassurance, being present at appointments and practical help around the house with daily tasks can help reduce psychological burden on the pregnant woman. And then after pregnancy, having continued emotional and practical support aids during the recovery, and then the adjustment to the new family dynamics can also significantly reduce postpartum stress.
Thank you. I don't think we can say that enough. And then one of the things I guess we also talk about, I think, Relicious, when you and I have our one-on-ones, is that the partner doesn't necessarily have, I made a mistake. I said the father of the child, but the partner could be anyone that is in her village.
Yeah.
Her older brother, her younger brother, her twin brother, her granddad, her dad, right? It's just having that additional voice. I know we are running over on time, but there were so many gems. We are going to do a drawing for those who are still here, and Birthing the Magic is going to gift you a signed copy of Dr. Angela's book. And so our intern did the drawing. She took all your names that were on like 5 minutes ago, and she drew Shauna Brabham. I may not be pronouncing your name right, Shauna. We should have your email. If we don't, I'm going to drop my email in the chat, and then we can connect. You give us your address. We will send you the signed book from Dr. Neil Burnett. It is one of my favorite books of all time in terms of just managing how life is lifing at times. We want to thank Dr. Connor. I can't say enough about the work that she and her team are doing. Please take the time to go to our website. If you have questions, they have a contact button. And understand, for those of you who are the grandma, the auntie, the neighbor, the nosy woman at church, tell your mamas about the importance of creating this village. And Dr. Angela Neal Burnett, thank you, thank you, thank you. I want your support in every community in this country. If I was queen for a day, I would do it.
Thank you.
I just think it's so critical. And then we dropped her book in the chat. We dropped her lab in the contact for her lab in the chat. If you want information about setting up this, her initiative, her sister circle in your community, she is a brilliant support for around that. And then lastly, Relicious, you're just part of the family. So we thank you, we appreciate the conversation. And one day we're going to talk a whole lot about that support network and the importance of the partner. But for now, we're going to have to say goodnight, and we'll send the recording. And thank you, ladies, so much for your time.